stop. What is happening to our discipline? We are at a crossroads. We move towards family medicine. We move to continue to move in family medicine, or we move towards public health. Are these different? Are they same? I would try to put forward my views on this. Before I start, if you have read Alice in Wonderland, Alice, when she is lost in the Wonderland, asks the Cheshire Cat. When she comes to a fort, like we are in my initial, where should I go? The cat asks, where do you want to go? Alice says, I don't know. So Cheshire says that it doesn't matter which road you take. So I think this is the crux of this question. We have to know where we want to go. And I am not sure whether we know where we want to go. So I am going to give you my thoughts on this. I do not claim that I have all the answers or what I am saying is the only right way. But I would definitely feel that there is a need for us to discuss and debate this issue. And come to whatever conclusion as a group, as an individual that we come to. I do not aim to antagonize anybody, but in case I am too forceful and people think that I am going to do a lot of self-criticism. It includes me. But in case you feel that my criticism is too strong, I apologize in advance. But what set me thinking on this topic? But that I have been asked this question by many people, especially the young generation, including the new faculty at AIIMS. They have a School of Public Health there, they have a Department of Community and Family Medicine. What are we going to do? Are we part of family medicine? Are we not part of family medicine? Is it what we are supposed to do? Is it what are we trained for? Why have a School of Public Health and Community Medicine? What are we supposed to do? How are we different? Are we same? So these issues have come up. And to some extent, the Vice Chancellor also raised this issue. He made a pitch that we should move in terms of family medicine. There are lots of schools of public health, but mainly in the last IIPSM conference in Tripura, there was a discussion in general body about membership of IIPSM. And I could sense we voted to keep people from MPH and other things out of the general body. There were very few dissenters, I was among the dissenters. But I could ask a senior colleague of us, why don't we make them our partners? Why are we voting against them? He said that is required strategically. So I don't know what that strategy is about, or whether we really have a strategy. But so my talk addresses these two: confusion as well as a sense of threat that we have today. Are we threatened by these schools of public health or by coming of family medicine? As well as there are discussions in our department itself, which also raise many of these issues. As is true for the whole fraternity, our department also has different views on this, and it is right that we differ in our. It does not, having differences of opinion is not wrong, but not coming to a mutual consensus might prove harmful to us. So I am going to try to answer this question: whether we are same discipline, whether we have come from the same origins, whether we do the same things, and try to understand the threat that was told that exists, and then if some suggestions on how to move forward. So how did our discipline come up? The department, the discipline of community medicine. I can frankly tell you many of these things I have worked for myself. It is not taught to many of us, and many of us are not aware of it. I don't blame you. I was also not aware of it till I started working on this talk. So clearly, blame does not lie with people who don't know. It is with maybe and some people can say what I am saying is wrong. But then where is the document? Is there a document which tells us all these things? Frankly speaking, no. The term community medicine was first used, it is the American experience. Possibilities of community medicine, this is 1920 in American Journal of Public Health. What they said was that it is used in opposition to individualistic practice of medicine. Before this, there used to be individual consultants, clinicians used to make house visits and provide care. Moving from an individual-based practice to a clinic-based practice, group medicine, cooperative medicine, is what was where the term of community medicine originated. And the idea was to address inequities, cut costs, because it was too costly for individual consultants to visit houses. The cost of care was too much. If you look at UK experience, again it tells the same things. It but this is much later, 1974. What is community medicine? Newly found specialty of community medicine. What are they going to do? And if you read this article further, it's a small article, hardly one page. It says that again, when we are moving from house visits by physician to clinic-based organization of health services, the job of community medicine is planning and delivery of health and related professional services, epidemiological and statistical analysis for priority setting in a community, and focus on social determinants. I would say even today, these are the three most important areas that we are taught and we practice. So this definition and the original seems to be in keeping with at least what we are doing and what we are teaching. And coming back to for everything we refer to board committee, and for our discipline also to some extent this sort of provides us the basic background for what we are supposed to do. Board committee recommended creation of Department of PSM in medical colleges so that we can create basic doctors. And in basic doctors, we meant, or the committee meant, that not only one who provides clinical care, but also takes care of the other, who engages with the community and takes care of all health problems of the community. So that was the reason that the departments were created in medical colleges. And to do that, it said we should set up rural and urban practice areas. We should teach principles of prevention and investigation of community health issues. So our existence is because of undergraduate teaching. So obviously any discipline gets actually identified by the postgraduate teaching, because that is where we are able to flesh out the details of our discipline. MBBS just provides us a platform. And for that, the board committee said that should be done in specialized medical colleges and only in public health institutions. But then we moved from PSM to community medicine. It was largely an image makeover. I don't think I am not the right person to answer. I was not there when this decision was made. There would be some people in the audience who would be there, who would be better informed than me in this regard. But it was largely, we wanted to move away from being doctors of latrines and mosquitoes. We were not happy with that image. We wanted the image makeover. I see nothing wrong with that. So don't take it as a negative thing. This discussion, I am told, occurred in Udaipur AIIMS conference, when this discussion of shifting from PSM to community medicine occurred. And it was decided that we will move towards community medicine. And then a lot of medical colleges took their own time in moving it, but some are still called as preventive and social medicine. But I am more interested in this choice of community medicine over community health. I am told that in that meeting there was a lot of discussion, community health, community medicine. But we ultimately chose community medicine. Perhaps we want to focus our clinical roots, because medicine is more clinical, health seems to go beyond clinical. So the fact that we decided to continue with medicine rather than go to health, to me gives a message that we want to keep that clinical identity for us. We don't want to move away from it. In that discussion, nobody talked about public health. We did not discuss, the fraternity did not discuss whether we should move from PSM to public health. That did not even come on the agenda. Reasons I don't know, as I said, I was not there. And we all know we have worked very hard for this discipline to be recognized as a clinical discipline in MBBS. So it is clear that we are very particular that we should be clinicians. It seems to be the one that gives us identity, more than the community part of it. But as I am just shifting my emphasis to the other aspect of history of public health. History of public health is entirely different from history of community medicine. It is much older, and it started with general vaccination, John Snow, germ theory, and the focus was sanitation, latrine, ventilation, and especially after industrial revolution, a lot of work on factory workers, military, then on legislations like quarantine, vital legislation. So the origin of public health internationally, globally, is very different from origin of community medicine. They don't come from the same stream of thought. But in US, somewhere along in early 1915, a clear-cut decision was made that public health is different, clinical medicine is different. This is by what they call as a Welch-Post report. And they clearly, after that, the schools of public health came up in US, which had nothing to do with medical schools or doctors. They were a completely different set of people, anybody could join. But that clarity was there in US, and which is what led to the so-called public health schools in US movement. That distinction is not very clear in our setup. We are not very clear that public health is different. That kind of thinking is not there in the Indian. I am not saying that that's the right decision. We may not, as Rajesh Kumar said, US model is not always a good one to follow for everything. But are we clear? Is there a deliberate discussion on this issue that we don't want this distinction, that we want to maintain deliberately blur the distinction, or is it a good idea that we clearly do? Is it harming us as a community medicine, or is it benefiting us? Many of the times, in many of the discussions that we go, invariably when the discussion on public health, it invariably moves towards healthcare provision, rather than actually talking of many public health core subjects. The whole discussion is taken over by clinical provision of services. So, is that will continue to happen as long as we have a combined model. A distinct model enables us to clearly differentiate these two. So, we have to be clear what is it that we want to do. And in order to further confuse more, there is also a term called as public health medicine in many of these UK, Australia, and Israel, where they look at clinical epidemiology and evidence-based medicine as their basic disciplines. Again, you can see that there is a lot of overlap there. Largely, they use this term similar to community medicine. And Ruth Bonita and Robert Beagle-Hole, who were in WHO before, in their book on public health at crossroads, say that this is not a good sign. Even though it is good for clinical epidemiology, it takes us away from the main challenges of public health, and therefore is not a good direction to move. So we have understood how the evolution has occurred. Now I am putting forward, this is my idea, you may not agree with me, but is there an overlap or community medicine between these three disciplines? Dr. Farooq Ahmad, who is a senior member of our fraternity, had written an article in the Indian Journal of Public Health in 2008. He was of the opinion that these subjects are same. We must be convinced that public health, social preventive medicine, and community medicine are conceptually and structurally the same discipline, fulfilling the Winslow's definition of public health. And he went on to say that therefore we should work together and etc. etc. His contention was that we are same, therefore we should work together. You will see later on, my contention is that we are different and therefore we should work together. So our aims are same, our recommendations are same, but where we reach, how we reach there is different. Largely, since this does not enable me to interact with you well, I would assume that many of you would say that they are same. Again, as I said, I am not saying that is a wrong opinion. This is my opinion, that could be your opinion. You are free to continue to hold that opinion. If you change after my talk, good. If you don't change, that also is good. Trying to look at the clinical medicine versus public health and community medicine. Clearly, we know clinical medicine has three levels. We talk of primary, secondary, and tertiary. In primary care, you see MBBS, secondary care is MD, tertiary care is DM. Just a point here, even in primary care, actually dental and nursing are always in any setting part of primary care providers. Unfortunately, we don't include them, but that's a different topic. I'm not going in that direction, maybe some other time. My proposal is that public health can also be done at three levels. Which I call them as micro, meso, and macro level. Micro is when you work at community level, for which you will require, maybe you cannot read it well, basic epidemiology, biostatistics, demography, social and behavioral sciences including ethics, and basic health administration. Largely keeping in mind what is required to work at community level. Second is at the organizational level, which could be a district, which could be a company or organization, industry, even you could take states. And the focus is on health system administration, program evaluation, project management, healthcare financing, occupational industrial health. And third is it's a national government or above, globally, health economics, public health laws, public health policy, global and international health, political economy of health. And there could be quibbles about what is here, what is there, but we could conceptually think of public health can be practiced at three levels. But it is important to know that this is not hierarchical, unlike the clinical medicine. I am not saying that people who work here are worse off than people who work here. These are three different levels, and we cannot compare. You can't say that these people are senior or better, doing much better public health than people are working. I think that would be a wrong thing to say. And people can work at one or more levels simultaneously. So this distinction is a bit different from the other of clinical medicine that I'm doing. Many of us could work at all the three levels and do a good job of it. Why is this? I'm distinguishing this. This is because this is how I define community medicine. Now we know this pillar of clinical medicine and this pillar of public health are two separate. They need not, there is no overlap between them, as is the US model. But the problem and the confusion arises because community medicine as a discipline bridges these two models. It takes something from clinical medicine, which is largely primary care, and takes at least meso and micro level work in this. Largely, I would say from my experience, and I have talked to many people, that these topics are not taught at all to us, even in our MD, or taught very superficially, just to say that we cover them. But largely, I don't think any one of us, and that includes me, who has done MD in community medicine, are trained to handle health policy issues, health economics, legislation, trade issues. We are not trained. I am not saying it is good or bad, but it is a fact that we are not trained. And therefore, while public health includes all of them, community medicine takes a good part of public health, combines it with primary care, and has created a new discipline of community medicine. This is as I understand what community medicine. If I have to explain, this is how I would do it. But when we teach MBBS students, we generally restrict them to this level, which is right, because this is what is required for them to be a basic doctor. And therefore, we teach them the primary care and the basic level of community medicine, which is fine. Whereas when we go to the PG level, we teach them this. As well as maybe this is a bit contentious, do we really teach them more in clinical part of it, or we restrict it to what they should go as an MBBS? My gut feel, and as I discussed with others, is that we really do not go beyond primary. So one of my contentions is for the house to think about or whatever is, in the primary, in the MBBS, we really don't teach them clinical medicine. That is taught by clinical departments. We help them provide a platform to maybe in our like in Lucknow to learn it, or also help them engage with community. We are not really providers of clinical care. And in our MD, we do not give anything beyond MBBS. So why are we so much obsessed with having a clinical tag? Why do we think that we are clinicians? And so something for you to think about. I am okay being a non-clinician, but you can say that I can do that at my stage of life, but that's a different thing. Family medicine just looks at part of this, but pushes the envelope here to a much more secondary care. Obviously, it does not take all the secondary care, but it takes a good amount of this, and therefore also bridges to some extent, but it takes a different path. So this is how I try to see these three departments, or if they coexist, or at least three disciplines as having. Now that is a theory. Does this apply to practical sense? With my experience in NCDs, I am going to see how NCD prevention control, these three departments would work differently. You may disagree with me as I said, but then how would the Department of Community Medicine work on which areas of NCD prevention and control? Assessment of community needs, managing NCDs through primary health care, including role of ASHAs, Anand workers, AIIMS, etc., etc. How should organize NCD-related services? What should be there at the sub-center? What should be there at PHC, district level, etc. And setting guidelines for that. Assessment of quality of healthcare, including access, equity, and coverage. Health insurance. And again, come to the debate today. Do our community medicine people really need it for provision of care? My answer is no, but I am aware that some people might say no, yes. So we could be providers of care. What do family medicine people do? Serve as a first level provider, as family practitioner. They also work at secondary level and can manage many of the common major NCDs as an integrated approach. Family level interventions in diet, physical activity, counseling of family members, and household screening for this disease. And where would public health people work on? They will work on tobacco legislation, alcohol, injuries, working with private industry, marketing, or regulation of marketing of food products, international treaties on tobacco, intellectual property rights, work with agriculture sector, education sector, urban development sector, health impact assessments, policy planning, analysis, and evaluation. So these are the three distinctions. As I said, there could be some overlaps, but largely this I see as three divisions. Now I'm going to take an example. This is a published example from Iran, where they started in the Shiraz University Medical School, where they started Department of Community Medicine in 1971. The objective is exactly the same, to train physicians to the community as a whole, so basic doctor. Then they moved and started a School of Public Health. It was created, and the author says at the cost of belittling the Department of Community Medicine. The epidemiologists, environmentalists, and statisticians were moved from Department of Community Medicine to School of Public Health. So the staff was basically split, and some of them went there, some of them stayed in community medicine. And as such, we know in India there is a scarcity of faculty members. So we further split them into School of Public Health Community Medicine. This is something that we want to do. Department of Community Medicine mainly considered themselves. This is as per the Iranian experience and that paper. As clinicians, and university administration has a problem in distinguishing between family medicine and community medicine. They wanted to start this primary care providers, family health practitioners. Do MD community medicine people qualify to be a family practitioner? The health system there, ministry did not know. They had no answer. And obviously schools of public health usually do not have a community. They work more at theoretical level. So people who are pushing for public health votaries say community medicine has resulted in lowering the multidisciplinary activity because we are doctors, we are too much medicine centric, we do not engage with other departments because we are inward looking. The focus is on healthcare services. It is only medical college based training, and as we saw, we really do not get trained in many expertise required for a good public health, like policy, legislation, trade, etc. Whereas community medicine people, when they argue that no, we should be separate, they say public health training is usually not community or health system based, which is what we are trained for, which is what we should be doing, and which is what is the need of the country. Inclusion of non-health actors in public health lowers the status of public health. If anybody can become, if a lawyer can become a public health specialist, if a nurse can become, if anybody can become public health specialist, then what is the point? There is no specialism. In fact, in Malaysia, they refused to give public health specialist post a specialist because they said that it is anybody can become public health. We are nothing special. But public health training has very poor quality control as of now, and definitely it is not the same status as therapy, and definitely not appropriate for teachers and medical colleges. But again, I am not getting into the debate, but some of the issues, as I said, for us to ponder. Are these differences between community medicine, family medicine, or public health theoretical, or are there more conceptual issues there? Do we have a territorial walls on them, or no, in the colleges? If we think community medicine, public health are same, which is what many of us say, then why have this hesitation to include non-medical people as a part of our fraternity? Why do we want to exclude them? Why are still the name persists, confusion in the name persists? And largely, most of us actually do not practice community medicine. We just teach community medicine. That is one of the things that we also have to ponder. If you don't practice it, clinicians practice and then they teach, it makes sense. But do we practice, or we are just teaching them? And do we really understand what is public health approach? Again, this is not that clear. Many people don't really understand what is public health approach. Most of them feel that community medicine means that we are clinicians, because we are clinicians, our job is to make services available. I would like to take a different route now to make people understand what is a public health approach. The aim of health sector is to make unhealthy people healthy. I think that's not very difficult to say. So we put people from unhealthy sector to health. That's our job. But to do that, we can take individuals and then convert them from unhealthy to healthy and keep doing it till majority of them become healthy. Right? This is clinical approach. When you take one individual at a time and convert them from unhealthy. This is what is clinical approach. But we know that this cutoff is arbitrary. That is what public health approach tells us. We actually, it's a distribution. And we cannot really say beyond this it is healthy. We make cutoffs, but they are all not. And even healthy people health needs to be taken care of. It is not that we only focus our attention only on unhealthy people. We need to look at healthy people also. So our job is what we call as the shifting the distribution to right or left depending upon which is more healthy. Here I am taking it as the other side. So we actually don't take individuals. We are not, because our this thing is different. We use a different approach and therefore shift the whole distribution to the right. We don't work with individuals. We work with groups of individuals or communities. Size could be anything up to you. But still there will be some people left here. If those people here using this to move this is again cost effective. It is not good. It may be very, and therefore we also use, so this is public health approach. But for people who are on this side extreme, we need to use them the clinical approach. So ultimately both the approaches are needed, clinical approach and public health approach, if you want to have a healthier population. The choice of approach depends upon the context of the setting. But again, asking the group some questions for you to think about, which one of would you like to become? This is much more glamorous. Obviously this is not a glamorous job, which is why we want to be clinicians and don't want to be public health. And that's why we cling to that clinical tag, because that is glamorous. Which one are you trained for? What does your training, which I mean MD in computer medicine, trains you for? And which one are you practicing? I think each of you have to think about it and answer it yourself. And as an association, we need to think, what are our medical colleges doing? What are they teaching us and what are they practicing? Going slightly more into detail about clinical versus public health approach, you can read more detail in my recent article in National Medical Journal of India. Clinicians take individuals, they make individual diagnosis using clinical signs, symptoms and laboratory symptoms, laboratory investigations, whereas we take communities, make a community diagnosis by using quantitative and qualitative approaches. So the approach is same, the tools are different. Their aim is to cure the individual by individualizing treatment, and their tools are drugs, vaccines, surgeries, counseling, etc. Whereas public health, we either control, eliminate or eradicate depending upon the disease. We standardize treatment, and our tools are policies, programs, guidelines, campaigns, legislations, health education, etc. How many of us are trained for this? To define, make policies or programs or developing guidelines, campaigns. Our training still focuses more on this. So there is some level of disconnect there. We use a much more complex social model. It talks about multifactoriality. We have an horizontal approach. We work through Panchayati Raj, health systems, private sectors. But clinicians have a much simpler framework to work on. They work on the assumption that they are doing best for the individual, whereas we are working on good for the large part of the community. And we know that often there can be a conflict between these two. But we have consciously chosen that what is better, good for most is better than what is best for few. We look at equity and those kind of issues where they look at how good effectiveness of treatment. This is much faster acting, this takes much longer, and this is reversible. People can move from unhealthy to healthy to healthy to unhealthy, but it's very unlikely that a public health approach in the shift distribution, it will go back. So while we value our clinical background, by our discipline we should practice public health. Now I am moving from the confusion to the threat. As we saw that we have an identity crisis, but this naval gazing is not specific to India. It is not, we saw it is there in UK, in many Iran, everywhere. And nor is it a recent phenomenon, it has existed. Because our subject is difficult or a bit diffuse to explain. We cannot describe our discipline to a layman. In one of the recent meetings, Dr. Rajesh Kumar was also there. In Trivandrum, the group asked, there was a very heavy panel there, Dr. Tangappan, myself, Dr. Rajesh Kumar. Sir, can you describe our discipline in one sentence? And I can tell you it was not possible to do it. So we also failed. But that is what set me thinking on this. So you see, I have started trying to make amends, I am trying to get this concept clearer in my head, and maybe tomorrow I can explain it to you. So I made some effort towards that. I am sure I will reach one sentence in some in the future. Worsened by newer disciplines of public health, family medicine, our IT crisis is worsening. We have split personality. Rather than 2, now we have 3 personalities or maybe 4 personalities. Discipline itself is changing over a period of time. Are we doctors or are we managers? Again, there is a conflict. So how much clinicians we are or how much we are not. And epidemiology is no more prisoner of public health specialist. We used to say epidemiology is our subject. It is the core of community medicine. But now everybody teaches epidemiology. Clinicians teach epidemiology, even non-clinicians teach epidemiology, surgeons teach epidemiology, everybody teaches epidemiology. So what has happened? Should we be worried about it? If yes, what should we do about it? We have low self-esteem. It stems from identity crisis. It also, from my point of view, we don't practice and therefore we have low self-esteem. If you only teach theory, we are going to be in trouble. Prevention is always going to be less fashionable. And are we man behind or in front of the camera? Are we the director or the actor? Again, clinician or managers of clinician. Actors get all the credit for a hit film. Directors usually don't get credit. But does that make the director's job any less? Should directors be worried that we will not be director, we will become actor? But they will not be a good actor. They are a good director does not mean that they are a good actor, nor is a good actor a good director. And multidisciplinary nature of this subject is it our strength as well as weakness because it causes confusion. We have a lack of role models in India, lack of attribution of public health success to our leaders. How many diseases in India, which I will come to next, or globally, can we as a practitioner of community medicine claim that this was done by us? If it is water supply, sanitation, environment, they take credit. If it is good surveillance system, demographers and statistics take credit. If we improve health, clinicians take credit. So where do we go? This is what CDC rated as 10 greatest advancements in public health in last century. Child mortality, immunization, water supply and sanitation, malaria, HIV, AIDS, tuberculosis, tobacco, road safety. What is our contribution to this in India? Maybe somewhat we can claim some credit here, but here also pediatricians can also claim credit. Maybe IAP has done more work on this than IAPSM has done. But more importantly, this is the future. Climate change, health promotion, working with industry, international pandemics, travel, reducing cost, mental health, health impact assessment, trade and drug industry issues, urbanization. Are we prepared? We have not done a good job, in my opinion, of the past. But are we ready or are we prepared to do something better in the future? What are we doing about this? Nothing. We are nowhere here. We are not even teaching. We are not discussing. So something for us to think about. The environment is changing very fast. We cannot control the environment. In fact, today somebody can question, and sometimes it might come, is the concept of basic doctor, which is what led to the establishment of departments of PSM in all medical colleges. Is it relevant? Do you think we really need, in today's way, do you think there is going to be, is it an idealistic thinking? It is never going to happen. We don't need basic doctors because no doctor is going to work and engage with community. Forget it. Then the whole the discipline, the department's existence comes into question. Only the wisest and the stupidest of men never change. And I leave it too slow, it is not able to react to it. Maybe we are like that. Our environment has been changing for a long time and we have not changed. So maybe if we continue like this, our doom is not too far. We also feel threatened because there is a mismatch between threat and our strength. If you are weak, you will feel afraid of very small thing. If you are strong, you are not going to be afraid of things. So is our feeling of threat more because of our weakness than because of the threat itself? For example, we keep saying that Hinduism is threatened by a lot of other every possible religion. Hinduism is actually quite similar to public health. We cannot define what is Hinduism. We cannot define our discipline. Anything and everything is Hinduism. Anything and everything is public health. But the reason why Hinduism has survived is that we have assimilated everything. Hinduism has never fought any war against any religion. It has just assimilated everything and made it. That is the strength of our discipline. Take everything and go forward. That is what we learn. Similarly, even opening up of international liberalization, India was very hesitant to liberalize. We were afraid that we will be swamped. But today we think we should liberalize because we feel we are strong. We can go and take over African countries. So the change has occurred over 20 years. It is changed because we feel we are stronger. want to change, we have to strengthen ourselves. What do we feel threatened by? Historically, we were threatened by clinicians. Today, we say we are threatened by non-clinicians. How can this be? Then we are afraid of everybody, basically. यदि हिंदी फिल्म के इसमें लैंग्वेज में बोलूँ तो जिंदगी जिंदा दिली का नाम है मुर्दा दिल क्या खा दिया करते हैं. But that is the fact of our life. Right? How can we survive if we are afraid of everybody? Why are we afraid of everybody? I cannot say whether things will get better if we change. But what I can say is that they must change if we have to get better. So I think we are in a cusp where we have to change, and I am asking this for to the younger generation, but also requesting the senior generation to take the lead and provide us how we can change. Some suggestions from my side. For example, I said epidemiology, everybody becomes an epidemiologist. Should we be worried about it? I will take an example of computers. When computers came, computers knowledge was very specialized. Most of us did not know. Then we learned some course. Now everybody knows computers. So should computer experts become worried? तो सब लोग जानते हैं कंप्यूटर? No, because they are not going to become experts. They have evolved. They have learned higher levels of computers. They have gone to much advanced area. Similarly, management. Everybody should know management. It's a basic, essential life skill. Then do IIMS of Ahmedabad have a sense of insecurity? No, because they practice management at a much higher level. The problem with us is that we practice basic epidemiology, which now everybody knows. Unless we improve our levels of epidemiology to much higher level, and world epidemiology has gone much beyond study designs, biases, confounding. We have much more complicated epidemiologies, which we don't learn, we don't teach. But that is something that we have to do. Some basic skill is required for everybody. But if you want to be specialist, we have to have special skills. What are those special skills? Do we have them? Build on strengths. Public health approach is what differentiates us from clinicians. Follow it, flaunt it. Our specialty bridges the chasm between medicine and public health. Our strength is working outside the hospital. Move out of medical college, work with district, state governments, communities. We will always be a primary care clinician. There are much better clinicians than us. If I might say, we will always be a second-grade clinician. But we can be a very first-grade public health practitioners. Why do we want to be a second-grade citizen and not a first-grade citizen? Take clinicians to the community. That is one of the great services that you can do. There are a lot of people in AIIMS who come to me, we want to work in the community, we don't know. Please guide me. That is our way. Take them to the community. So we need to bring clarity in our thinking. If we voted for a particular thing strategically, what was our strategic objectives? I don't know, nobody has told me. Educate the students about our discipline. Develop sub-disciplines. I think it is time we started thinking about DMs in epidemiology or public health nutrition or PhDs. We are just stuck at MD level. Go beyond. We need to increase our technical expertise. Market ourselves better, which are the 5 P's of any marketing. My question to you is, are we a niche product or are we a mass product? Niche product does not require marketing, big marketing. They are not targeting big people. They are targeting a very fine market. They know this is their market. Their marketing is very different. Their market is very small, but it is very different, and they can do it. Whereas the mass market is like chips. You are marketing to everybody. Are we saying that community medicine is a niche or is it a mass? I don't know. I don't have an answer. But these are some things that we need to think about, because we can market only after we know what the product is. If you go to a marketing expert, they will first try to understand your product. What is community medicine? Then only you can market it. Do we know what we are? So should we go for placement, which is for niche, or we go for numbers? Strengthen institutions. Understand and respect differences between public health, family medicine, community medicine. There is space for all of them. Let them all flourish. Do not create artificial boundaries between these departments. Have something like Euro where people can move around countries. National boundaries are disappearing now. Hopefully in somewhere in future we might also have such a thing in SAR, where boundaries will become meaningless. So we are increasingly, the world is moving in terms of no boundaries. So even if you have 3 departments in a medical college, think how you can blur the boundaries there. Have formal collaboration mechanisms and joint programs and share responsibilities, resources. Finally, give partners equal treatment. If you want non-medical people to be part of it, you have to make them equal partners. If they are the head of the department, you have to give them the head of the department. We cannot say that they are our partners, but not give them equal weightage. We have to give them equal partnership. If we want to really practice what we preach, we have to make them our equal partners. Some advice for IIMS, maybe are too small, but I think we need to encourage diversity, discussion, debate, but move towards consensus. Strengthen teaching, which should be a primary job of the association. You may need to revise the curriculum, for MD especially, develop sub-disciplines, hold regular CMEs, build partnership with other public health stakeholders. We have not only moved from self to individual, family, community, public. Now we are kind of global health, planetary health, with completely different set skills. Where do we go? So in the end, I would like to say that these are three distinct disciplines, but there are a lot of commonalities. Understand and respect differences. The perceived threat is unwarranted, but is a reflection of our weakness. Understand public health approach, use and promote it. Be more inclusive, establish partnerships, and strengthen the discipline and association. I started off being lost. What is my way forward? All three are appropriate for an individual to go, as long as you are true to the approach chosen. Some of us may have more clinical. If you want to stay clinical, we can continue in family medicine. Some of you don't want clinical, they can go to public health. So choose based on your aspirations and strengths. Ultimately, all three converge to improve people's health. So there are three different ways to the same goal.